Nirala is a licensed naturopathic doctor from the USA with a growing practice in Australia. She is considered a leading expert on the natural treatment of SIBO in Australia. Nirala has worked in the natural healthcare industry in the United States and Australia for 20 years and has been in clinical practice for 16 years and has lectured internationally on SIBO to both lay and professional audiences. Treating patients with SIBO in her own busy Barton clinic in Queensland led to the creation of, in 2012, of SIBO Tests, a specialised team with clinical experience in testing for and treating SIBO using natural medicine. Nirala was a 2004 Delphi panellist at the first SIBO Symposium at the SIBO Centre in Portland, Oregon. Okay, so I'm pretty blown away by that already. So, very impressive. But before I go on any further, I'd like to introduce Nirala. Would you like to say a few words?
No, thank you for that very broad introduction. That's great. I've been really interested in digestive disorders for quite a number of years, as probably many of our listeners tonight. It's sort of the meat and or bread and butter of our practice very often, because we see so many digestive disorders. And I was just, when I first stumbled across it in 2009, I believe, I was sort of floored that I had never heard of SIBO. I pronounce it SIBO, so SIBO, SIBO, tomato, tomato.
Yes.
But so I was just really shocked that such a prevalent condition was never really taught. Even at Bastyr, where I went to university, we'd never really kind of covered that. And it's been around for quite some time. It's just that Dr. Alison Siebecker and Dr. Stephen Sandberg-Lewis, who teach gastroenterology at several naturopathic universities in the States, they gave a presentation, and really it was kind of revolutionary for me, because probably like many people that are listening, we have very good, we get really good results with digestive disorders, but there are a number of people that just basically relapse or they just don't improve, even though you think that your treatment plan is really well indicated. So that really led me down the road to looking at SIBO a lot more closely, and then developing SIBO test, because I was so disillusioned with the testing that was available here in Australia. So I've given a lot of talks and lectures and webinars basically for people that are interested in the topic. And some of you may have actually listened to a couple of lectures that I did for Biomedica a few years back. And so there will be some overlap in tonight's presentation, but I thought I'd just start with the basics and then get into more interesting topics later on. But really what I want to cover is, what is SIBO? How do we actually test for it? What other systemic conditions are associated with SIBO? And it was a real surprise to me, because there's a lot that has sort of SIBO as an underlying condition as well. So I kind of want to cover all of that, and I welcome your questions as we go along. And I think you all have the PDFs, and I've made just a couple of changes, so just bear with me, and I mean to see if I can actually advance my slides. Yeah.
And Nirala, as you start, I have received some information. Some people just talking about they weren't taught SIBO, and they're attending tonight to gain more information. So this will be perfect for that.
Okay, so excellent. So you'll get enough to get started, but what I want to say right off the bat is that in March last year, I did a really comprehensive webinar that if you feel like you still need more information, especially on the treatment of SIBO, I go into great details in this webinar, which you can purchase and download from the website, which is sibotest.com. And there's also, I'll talk to you later on about, there's a lot of practitioner resources that are free to use and access from this website. So as we go along, I'll sort of refer to that a little bit more. So, but yes, I totally agree. I was not taught anything about SIBO, and what I now know, I've treated literally hundreds of cases with this condition, and it's sort of like it keeps uncovering, and we find out more and more every year, especially in the natural treatment section. There's just a lot that we still need to find out and discover, especially when we get to prokinetics, which is an area of supplements that we'll get into a little bit later. But basically, SIBO, some experts claim that up to 80% of irritable bowel syndrome can be linked to SIBO, or will be testing positive on SIBO testing. When we think of what are the causes of irritable bowel syndrome and other functional digestive disorders, we think of food sensitivities and leaky gut, digestive deficiencies like hydrochloric acid and pancreatic enzymes, but also often our really stressed out and anxiety-ridden patients. But SIBO is a whole class in and of itself, so we'll get a little bit more into that. So I wanted to include this Rome 3 criteria because I think many of us didn't really get a lot of information about this. But back in 1990, the Rome criteria were formed or discussed in terms of how are the gastroenterologists, how are they going to actually diagnose IBS. And so it's a way of diagnosing IBS, but back in 1990, it actually was the alternating constipation diarrhea, it was the bloating, it was the abdominal pain, and over the years it has really been whittled away to where we now only see recurrent abdominal pain or discomfort for at least 3 days a month. I mean, our IBS patients have far more symptoms than 3 days a month, and associated with 2 or more of the following, which is improvement of their symptoms with defecation, and also that the onset was associated with some frequency of stool and or the form of the stool, so either constipation and or diarrhea. So I just thought it was really interesting because in the latest whittling away, they've completely eliminated bloating, which is so key for many of our IBS patients. So when we put SIBO in a nutshell, what is it actually? It is sort of dysbiosis of the small intestine, which means that it's an overgrowth of normal bacteria that are normally found in the large intestine, but they've migrated or stagnated for whatever reason in the small intestine. And it's thought of as a translocation of normal flora. We don't know why this turns pathogenic in terms of why does it actually cause disease. We know why bloating occurs, but there's a lot more that happens with SIBO in terms of systemic inflammation. But more importantly, what can also really go wrong with SIBO is that it causes this damage to the microvilli, which, as we know, is the absorptive surface of our small intestine. So when you damage that, you can have a lot of systemic malabsorption and nutritional deficiencies. It's also very common in other conditions, such as fibromyalgia and restless leg syndrome and others that we'll get into a little later. So when we look at the bacterial overgrowth in the small intestine, when we think about the small intestine, and I might just skip to this next slide here, what we have here is the duodenum, right? So if you think about, can you actually see my little arrow here, Raleigh? Yeah, okay, great. So the stomach attaches here, and the first part is of the small intestine is known as the duodenum. We don't expect to see to have any bacteria at all in this section, so 0 colony-forming units in the duodenum, and that's because of the protective mechanism of hydrochloric acid and bicarbonates from the pancreas. Hydrochloric acid, of course, from the stomach. Then when we get into the jejunum, we see a bit more growth of bacteria, and then we reach the ileum. The terminal ileum is this section here where the small intestine or the section of the ileum actually empties into the cecum here, which is the valve here is known as the ileocecal valve. So right here we do expect to see some bacteria, but let's see if I can actually go backwards. Yes, I can. When we see the ileum and the ileocecal valve, what we expect to see there is up to about 10,000 colony-forming units per milliliter versus about 100 billion colony-forming units in the colon per milliliter. So this is a huge and vast difference over just a few small centimeters of digestive tract. SIBO is anything that's over 10,000 colony-forming units per mil. Okay. So we really see a huge disparity between places. And when we see people that have bloating immediately after meals, we know that's fermentation, and it's often that bacterial overgrowth that causes that fermentation, as we'll see in a minute. So the normal antibacterial control of the digestive tract really starts with hydrochloric acid. It's our natural antimicrobial of foodborne bacteria and viruses and fungi. So as we know, when people are really stressed or have other sort of atrophic gastritis, they really have very poor output of hydrochloric acid. So we do expect to have more incidence of SIBO in patients with low stomach acid. But pancreatic enzymes and, as I've mentioned, bicarbonates offers more antibacterial control in the normal digestive tract, and bile as well. It is fairly antimicrobial. The other section of normal antibacterial control is your migrating motor complex, which is really a fascinating little unit of a cleansing wave that sweeps through the small intestine every 90 minutes on an empty stomach. And this is one reason, and I'll allude to this a bit later on as well, why we really discourage snacking between meals in patients that have SIBO, because we really want to maximize this normal cleansing wave that occurs. It's about 40 centimeters long, and chyme, or sort of broken down food, moves along at about 6 to 12 centimeters a minute because of this migrating motor complex. It's generated, this cleansing wave is generated by the enteric nervous system, and I apologize in advance for my acronyms, but I'm hoping you can make notes as you go along. So by this enteric nervous system, which is also under vagal nerve control, which we won't get too much into here, but it's another important part of your enteric nervous system, and also motilin. So both of these substances will, or mechanisms will promote the cleansing wave of the migrating motor complex. And that's really key in preventing a relapse, because as we'll see, many patients that have SIBO have a really impaired migrating motor complex for whatever reason. Sometimes it's because of an infection that causes a paralysis of your migrating motor complex. That's why it's so important to really understand if it's SIBO or just some candida or other sort of dysbiosis. So in SIBO, the migrating motor complex is impaired, and so therefore bacteria are not swept out of the small intestine in a normal fashion. You want to consider small intestine bacterial overgrowth in the conditions such as clearly with irritable bowel syndrome, but also inflammatory bowel disease, just because of such dysfunction of mucosal immunity, and often there we also see impairment in the small intestinal motility. Celiac disease as well as autism, fibromyalgia, interstitial cystitis, restless leg syndrome, I'd say, is really a key. If you've got patients with digestive disorders and restless leg syndrome, chances are pretty high that they do have SIBO. Acne rosacea, very much associated with SIBO. We call it gastroesophageal reflux disease with an E. We kind of drop the O, but you know it as GORD. And that's because when you think about that bacteria are in the small intestine and feeding on fibers found in foods that the patient is eating, then that gas production will actually push hydrochloric acid back into the esophagus. So we do see quite a bit of reflux with SIBO. Diabetes, very, very common, and that's because of dysregulated blood sugars, but also they often have enteropathies and neuropathies, which also impair the normal peristalsis of the digestive tract. Hypothyroidism, I wouldn't say it's causative at all, but we do see often a coexistence of these two conditions, and perhaps that's because of hydrochloric acid being decreased often in hypothyroid conditions. Scleroderma, the autoimmune disease that where we really do see a lot of skin involvement, and as we know, the inside of the digestive tract is epithelium, so we do see involvement with that autoimmune disease. Also non-alcoholic steatohepatitis or non-alcoholic fatty liver, you can see SIBO in those cases. Chronic prostatitis, very common, but I'd say You also can see a lot of candida in chronic prostatitis, and as well as sort of pelvic pain syndromes, as well as diverticulitis. So you can see that a lot of systemic issues that we don't really think about can have concomitant SIBO sort of coexist in the same patient. Classically, the symptoms of SIBO are the symptoms of irritable bowel syndrome, but very typically we see a lot of bloating and gas. I mean, these are the people that will tell you, you know, I bloat with a lettuce leaf, I bloat when I have a glass of water, I bloat with just about anything, and I bloat very quickly. We do see also either constipation and or diarrhea, and that depends on what kind of gas the bacteria are actually producing, and we'll get into that a bit later. We see a lot of pain, often because of the abdominal distension, but also because of the inflammation. We see belching, flatulence, nausea, reflux, very classically some leaky gut symptoms. We see fatty stools, joint pain, as well as skin rashes. So you've got your sort of smorgasbord of digestive symptoms and systemic symptoms. The causes of SIBO can be multifactorial, but very classically you'll have a patient that says, you know, when I was traveling and I went overseas to Southeast Asia, I got a case of food poisoning, and I've just never been the same since. That's a very classic presentation. And that's because, as we'll see later on a little bit, oftentimes bacteria that actually cause food poisoning, as we know now, they're not the bacteria that cause SIBO. As I've mentioned before, those bacteria that cause SIBO are your normal like normal flora that we normally see in the large intestine. But let's say we have Campylobacter or some of these more common bacteria that cause food poisoning. What we have discovered, not we, but Dr. Pimentel, who is the head of the Cedars-Sinai Hospital or Motility Center, gastroenterology in LA, has discovered that when you have a case of food poisoning, what happens often is that there's a case of mistaken identity or molecular mimicry, where the body tries to actually get rid of the cytotoxin B, which is the type of toxin that bacteria release that are foodborne illness. And instead of the cytotoxin B, the body actually attacks something called vinculin, which is part of your enteric nervous system. And so as a result of this food poisoning, we see a paralysis of the migrating motor complex, which is very common post-infectiously. So that's probably one of the most common causes. Then we also see, as I've mentioned, diabetic enteropathy, where we have a lot of digestive involvement, gastric bypass patients, because nowadays it's a little bit of a different story, but not too many years ago, gastric bypass that is left parts of the small intestine, parts of the stomach that were just blind loops. Pseudo-obstruction is mechanical obstruction without evidence of any kind of anatomical obstruction. And so this is where what we see is very irregular peristaltic action, not the smooth sort of consecutive section that are contracting, but very erratic peristaltic activity, which leads to pockets of stagnation. And what I usually tell my patients is it's just like a stagnant pond. So a stagnant pond attracts mosquitoes, and it's the same thing with the digestive tract. If you have areas that are just not contracting properly, you're going to have stagnation there. But often we see patients with adhesions, whether that's post-surgical or from endometriosis, but also people that have had appendicitis and had their appendix removed, cesarean scars, cholecystectomy or removal of the gallbladder. So you can see that pretty much your average patient can present with many causes of SIBO. In terms of medication, what we see are more the narcotics like morphine, codeine, also certain illicit drugs, heroin, and so forth. But a classic one is also proton pump inhibitors. And we, of course, see many, many patients that are on these medications. And what we now understand of proton pump inhibitors is that unlike, let's say, Zantac, which is a different type of H2 blocker, another antacid, but Zantac, for example, will block stomach acid by about 75%. And proton pump inhibitors like Nexium or Period can block stomach acid up to 100%. So that's a huge sort of removal of your natural antibiotic, which is hydrochloric acid. But also, proton pump inhibitors can cause leaky gut by themselves and inflammation. So we see, you know, I'm not saying everyone that's on proton pump inhibitors has SIBO, but we're just looking at what can actually be a contributing factor. Certain calcium channel blockers like Norvasc and other hypertensive medication, sorry, HTN is hypertension. Stress as well, and that would probably cover most of our patients, I would venture to guess. But one of the reasons is because of hydrochloric acid output decreasing in chronic stress. It, of course, increases in acute stress. But in chronic stress, we really see an overall reduction in hydrochloric acid output because the body is more sort of focused on running away from a perceived threat than digestion. So people that are in chronic fight or flight versus rest or digest are very often very compromised with not just hydrochloric acid output, but also their enteric nervous system, which is, of course, very, very important in the propulsion or the peristaltic action, will actually have some impairment of that because of stress.
Nirala,
Also, we see yes.
Sorry, Nirala. I guess, and this is, you're at the causes, so I'm probably jumping the gun a bit. But if you're seeing a client who's, as you mentioned, got the Zantac, which is 75%, or a blocker that's 100%, how do you approach talking to them to say that this could be influencing their conditions? Is that a conversation that most clients are happy for you to allude to or diagnose, or how does that?
Well, you know, unless somebody has Barrett's esophagus, which is the translocation of parietal cells into the esophagus producing stomach acid. In fact, I just had a patient today with it, and I'm still checking him for SIBO. I'm very certain that he has SIBO. But I always try to get people off of proton pump inhibitors, always, because I actually show them the FDA, Food and Drug Administration in the States, has put out a black box warning on proton pump inhibitors, not to use them more than 2 weeks, 3 times a year maximum, because of increased fracture risk, and that's because of poor absorption of minerals. So this is something I usually hand to them, and I say, look, you know, we need to get you off of these and really address the underlying causes as to why you actually have reflux. So barring Barrett's esophagus, I tread a lot more cautiously with that because, as you know, that's a precancerous condition. So we do need to be careful, but even there I try to, if somebody has SIBO and the gases are pushing the acids into the esophagus, that's an easy conversation to have with somebody. But just on that note, what I usually do is, because when you stop proton pump inhibitors from one day to the next, you will have a rebound hyperacidity because you now no longer stopping the production of stomach acid. And during the course of proton pump inhibitors, the stomach is so used to no acid that it also doesn't produce the protective mucus as much. So we often see more reflux or burning symptoms in people that just willy-nilly stop the proton pump inhibitors. So I usually say, you know, use your demulcents or use something that's very, very soothing, of course, and then move over to Zantac for a couple of days and see how you go. Zantac is just, you know, I mean, obviously I don't have any stock in the company, but it's something that will just help alleviate also some fear, because people don't like to just stop something and not have some sort of assurance that they're not going to get any kind of burning. Did I answer your question?
Yeah, no, thank you. No, definitely. If anyone else has got any questions, please just ask away. We're cruising through. We've got a bit over half an hour to go, so make sure if you've got any.
I got to get a move on it. Yes. Okay.
If you've got any questions, make sure you ask.
Okay. So also overconsumption of simple carbohydrates, right, is another cause for SIBO, as well as the initial colonization as the baby comes out of either the womb or just lifted out, as is the case in cesarean birth. So we do see a lot of just problematic microbiome that can already be sort of causing a problem later on as it then migrates. It's not the cause of the migration into the small intestine, but if you're starting off with a bad batch of bacteria already that are more Klebsiella and E. coli and Proteus and some of these bacteria that can cause SIBO, you're off to sort of a bad start. Some of the clues and indicators that your patients will tell you is, yeah, I tried Inner Health Plus or some of these other probiotics that contain inulin or other types of prebiotics. They actually get a lot more gassy. Sometimes people will tell you that their symptoms improve when they go on a course of antibiotics for sinusitis or bronchitis. That, like, when I was on that antibiotic for something totally unrelated, my digestion feels better or felt better. But oftentimes you actually have to ask those questions. They're not going to offer that. Also, when people are constipated, they come to see you and they say, I've tried the fibers, can't do the fibers, they just bloat me up too bad. That's often another good clue. And then symptoms worsen with alcohol, sugar alcohols like xylitol, sorbitol, anything that ends with an OL is usually sugar alcohol, and that will also be a fermentable sort of substance for the bacteria. Also, your celiac patients that just continue to have digestive symptoms whilst even on a gluten-free diet. So SIBO can cause the damage to the microvilli, which, as we know, are the little finger-like protrusions, well, actually, the finger-like protrusions are the villi, and the microvilli is the little hair on top of the villi. The microvilli can be so damaged that you have such a malabsorption of peptides that itself leads to food allergies and putrefaction of proteins. This then leads to leaky gut. The bacterial fermentation of disaccharides is probably one of the biggest things in SIBO, as well as the consequential gas production and bile acid deconjugation. So what happens is you eat something fatty, your bile, or you secrete a hormone called cholecystokinin, as we know, that squeezes the gallbladder. You release bile to emulsify your fats, which include, of course, your fat-soluble vitamins, your vitamin A, E, D, K, and essential fatty acids. And when that sort of combination substance then hits the small intestine, the duodenum, and everything gets mixed up and you have a lot of bacterial overgrowth, the bacteria actually uncouple all of that. So subsequent to that, that can be so bad that you can have malabsorption of these fat-soluble vitamins. And, of course, the impaired migrating motor complex, as I've described before. So the microvilli damage can be as bad as in a celiac case. And if you recall, where you have an absolute loss of microvilli, and that's pretty bad when you think that that's our only way of receiving nutrients from our food. The bacteria also eat the glycocalyx, which is the sort of mesh-like net that covers the microvilli, and on top of that is your mucosa. So, and all of that can be really damaged. And, that's kind of how leaky gut can develop when you have bacteria disrupting the mucosa and the glycocalyx. Then the brush border enzymes are the enzymes that are actually released by the microvilli. And these are enzymes, as we'll see in a moment, that are really crucial in breaking down or that final step of carbohydrate digestion. And when that's really missing, you have all those disaccharides that are just ready to be fed to the bacteria that are eager and waiting in the small intestine. So more damaging effects of the bacteria in the small intestine can be that that actually you'll also, not just your fat-soluble vitamins, but your patients will become very B12 deficient and iron and actually magnesium and other mineral deficient. And that's because of this disruption in the normal transporters across the small intestine. They also destroy bioflavonoids, and they hydrogenate your polyunsaturated fatty acids, so you have more sort of oxidative effects, and they produce nitrosamines, which of course are very damaging to the digestive lining. So leaky gut and SIBO is when you have too much bacteria present in the small intestine, and it's one of those survival mechanisms that we've evolved into, in that when the small intestine senses too many bacteria in the small intestine, it actually opens tight junctions. And this is something that we see also with severe celiac disease, is that tight junctions that zip the enterocytes together are opened so that water can come in and flush out whatever the irritant that is perceived can be. So leaky gut is a very common concomitant symptom or condition alongside SIBO, especially long-standing SIBO, I would say. Good news is, though, that what has been shown in research is that once bacterial overgrowth has really been treated and eradicated, that leaky gut is something that returns to normal within a month of treatment, and that's without your normal gut healer. So that's good news. So just as a primer of normal small intestinal digestion, is we know, of course, pancreatic enzymes break proteins into peptides and polysaccharides like amylose and amylopectin into disaccharides. That's a function of the pancreatic enzymes. And then as those substances move into the small intestine, we see a lot more brush border enzymes being released. Amino acids are going to be transported across the small intestinal, the brush border, but disaccharides cannot cross. They actually need further breakdown by brush border enzymes like lactase, sucrase, maltase, and isomaltase to be broken down into monosaccharides like glucose and fructose, etc. And so SIBO is where you actually have, because of the microvilli damage and the bacterial fermentation of these disaccharides, you really have a lot of these unabsorbed monosaccharides and actually also disaccharides. Let's have a little bit of a word about fructose malabsorption. It's commonly seen in SIBO, and it's possible, I actually suspect that it can be caused by SIBO simply because of or the damage to the microvilli. But fructose is actually a monosaccharide, so it's already broken down from sucrose, for example, as we know, is glucose and fructose. And it's a monosaccharide that gets absorbed in two processes. One is it's facilitated transport with glucose. So for example, if you have honey often is 50% glucose and 50% fructose. You have different honey variations or different types of honey that may be a little bit different, but for the most part you have a 50-50 glucose to fructose. In that case, it's going to be facilitated across the small intestine with glucose. So you're probably not going to have much problem unless somebody is severely a severe fructose malabsorber. But passive transport happens with the fructose carrier called GLUT5, and many Europeans and of European descent have very low levels of GLUT5. I'm one of them. So if I eat a lot of fruit, or even sometimes just a few pieces of fruit, it's just instantaneous bloating. But even in fructose-tolerant people, absorption is usually limited to 25 to 50 grams of fructose. And what we see in SIBO is that people just very often are very intolerant or to any kind of high fructose content food. And as we get into the diet, we're going to talk a little bit more about how we limit that. Clearly, we're going to remove fructose for a minimum of about 6 weeks. So I wanted to just to kind of briefly talk about SIBO-associated conditions, and there are more, but I wanted to focus on fibromyalgia, restless leg syndrome, acne rosacea, and interstitial cystitis, because we do see quite a bit of that in our practice. So just generally, what we see with SIBO is that there are very specific local and systemic changes. For example, we see a lot more inflammatory cytokines like interleukins and TNF-alpha. And we also see a T and B lymphocyte imbalance and activity, which of course is crucial in the small intestine where most of our immune system is. We also see more mast cell infiltration, and mast cells are the cells that actually contain histamine. And I have been delving further into histamine intolerance, biogenic amines in general, and salicylates and all of that is really fascinating when you see this kind of dysfunction on a microvilli level. This is where you see these patients that are just extremely sensitive, react to everything you give to them, etc. Of course, as I've mentioned, there's a lot of gas production from the fermentation, but also these anti-vinculin antibodies. Again, these are as a result of food poisoning, and not everyone will have these, and there's no way for us to test it yet. It's just that Dr. Pimento mentioned this at the SIBO symposium last year, and he's really doing a lot of research into this. And so it's very possible that in future, not too distant future, IBS, at least those associated with SIBO, may be reclassified as an autoimmune condition. So just a word on inflammation. We know that these that IL-6 and TNF-alpha and also lipopolysaccharide, which is something that gram-negative bacteria secrete that are pathogenic and can be absorbed across the gut wall and is a direct trigger for systemic inflammation. So fibromyalgia very much associated with that, but also other mucosal inflammatory conditions. I see this very parallel. Anybody that has a gut mucosal inflammation, I often see other mucosal sites. I'm sure you see the same in terms of bladder, vagina, lungs, even the prostate, all can have other sort of symptoms, even though the main driver of inflammation is in the gut, and that may be because of crosstalk of these cytokines. We actually have a systemic conversation when we see high levels of inflammation. So just about restless leg syndrome, and us just fascinated by this because it's one of those really horrible conditions that robs people of sleep, and it's a tough one to treat sometimes. There's a lot of different theories, low iron, dopamine dysregulation, etc., but about 32% of the people will have SIBO, so it is a big deal. Iron deficiency, of course, that's the #1 nutrient you'd think about with restless leg syndrome, is also very, very prevalent at 43%. And 95% of restless leg syndrome is associated with systemic inflammation and other immune disorders. So if I've just talked about IL-6 and LPS and TNF-alpha being raised in SIBO, so it's not a surprise that you have a significant number of restless leg patients also have SIBO. And one of the reasons why that happens is because IL-6, the inflammatory cytokine, is raised with SIBO, and what happens then is that hepcidin, which is an iron regulator molecule that sort of regulates systemic absorption and just basically regulates iron, because iron levels are usually sequestered during times of infection because certain bacteria actually feed on iron. So it's really important for the body to monitor that and to regulate that. But with high levels of inflammation, hepcidin actually reduces brain levels of iron, and so there's that thought that that's how restless leg syndrome can be linked to inflammatory condition, in particular to SIBO. And just giving iron is not the answer. It's the reduction of inflammation. So this is about acne rosacea, and I have had very good success with treating rosacea or treating SIBO and people's rosacea resolving. And there are 2 studies here where 46% of patients or 113 consecutive rosacea patients actually had SIBO, and in the States from Dr. Weinstock, who's another gastroenterologist, had 66%, found 66% of the patients that actually had rosacea were also SIBO positive. So there's a big correlation there. Okay, so let's talk about how do we test for SIBO. The stool tests are just not accurate. You can forget it. It's just that actually just tests for dead bacteria, and the small intestine is just so very different from the large intestine. So you can't make any direct correlation at all from your CDSA or stool test, complete digestive stool analysis, or microbiology profiles. It just does not correlate. The only sort of conventional test that's often used by gastroenterologists and by SIBO test is breath test. And what we do is we assess the gases that are produced by bacterial fermentation in the small intestine. And those gases are methane and hydrogen. And as of yet, we're not able to test hydrogen sulfide yet, and that's the third gas. Typically, if somebody is, or the third gas that's produced by bacterial fermentation in the small intestine, and typically people will talk about rotten egg smells, and they have halitosis that smells like rotten eggs, and flatulence that's like rotten eggs. So it's a really, really specific gas, although methane is also not very pleasant, as we know. So methane and hydrogen gas are not produced by humans. So this is one reason why it's so perfect for us to assess these gases. In diarrhea-dominant cases, we call that SIBO-D. These four bacteria are pretty predominant: E. coli, Klebsiella, Proteus, and Aeromonas. So these, again, we often find them as part of the commensals when we do a stool test. And they're not always pathogenic, although, of course, you can have pathogenic Klebsiella and Proteus as well. But in this case, they typically produce hydrogen gas. And then in constipated patients, we have the Methanobrevibacter smithii, which is a very specific type of, it's not even really a bacteria, it's in a class all in itself. These are the methanogens, or the bacteria that cause, or organisms that cause methane gas production, and that's very, very constipation related. Methane gas is the type of people that come in, they're constipated, they tell you that it's worse with fiber, and in animal studies where they've infused methane gas into the small intestine, they've actually reduced the transit time by 70%. So it's highly sort of paralyzing to the large intestine. So if you've got patients that are predominantly constipated and they need to take magnesium or a lot of different supplements to get their bowels moving, it's very likely that they have some sort of methanogen problem, as well as sort of enteric nervous system, of course, as you know. Hydrogen gas is more associated with diarrhea, but it can also cause constipation, but we don't really know why that's the case, because by far the methanogens will cause the constipation. But high amounts of hydrogen-producing bacteria can determine the degree and the severity of the diarrhea that they're experiencing. It's more associated with abdominal cramping and also very associated with fibromyalgia. So the breath test that we use, or that we offer through our testing site, basically what happens is that the patient has to go on a prep diet for 24 hours before the test. It's actually 48 hours if the patient is constipated, but all those instructions would be on the website and in the test kit. But then after this prep diet, they have an overnight fast, and then they get up in the morning and they do a baseline breath test, after which they drink a test sugar, which is lactulose. And then every 20 minutes for 3 hours, they take another breath sample. And then when we analyze it, we can actually really determine where in the small intestine their bacterial overgrowth occurs. So the lactulose is a non-absorbable sugar that's fermented by the gut bacteria into hydrogen, methane, or hydrogen sulfide gas. And only hydrogen and methane gas are actually absorbed into the enteric circulation. So after the bacteria ferment the sugar, they produce the gas is absorbed into the circulation and then brought to the lungs and exhaled. The rise in breath gases after a certain time frame is fairly diagnostic for SIBO. So in normal healthy adults, lactulose takes about a minimum of 2 hours before it reaches the section of the small intestine that connects to the large intestine, called the terminal ileum. And a rise in methane or hydrogen, especially in the first 90 minutes, is very, very indicative of SIBO. So we're the only lab, and this kind of goes back to when I first started out testing for SIBO. I was so unsatisfied with the test results because here in Australia, we have other labs and also hospitals that do breath tests, but they use lactulose only as a test sugar to see if you're sort of quote-unquote a fermenter or a gas producer. That very gas is how we test for SIBO, but because of the Rome criteria, and it gets a bit complicated and perhaps beyond the scope of this talk, but there are reasons why that was designated to be only a test sugar, whereas really I follow Dr. Pimentel, who I think is really foremost in the research into SIBO. He's done almost 20,000 breath tests by now, and he uses exclusively lactulose. So I feel very confident that lactulose is indeed a very good test sugar. But so back to when I first started, I would just get all these breath tests back where the doctor would say, or the lab would say it's negative, and I would consult with my overseas colleagues, and they'd say, no, 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 that's not how we do it here. So I've just said, okay, you know what, I'm just going to buy my own machinery, which I ended up doing, and that's how SIBO test was sort of birthed out of that because of my dissatisfaction with what was available here. So basically, we don't really have to get into that, but it's other labs use glucose, and I used to use a lot more glucose, which I've really kind of stopped doing after this latest SIBO symposium in Portland last year, and it really makes it a lot more streamlined just to do lactulose. So you can read that slide at your leisure because we have a lot more to talk about. So let's have a look at what it actually looks like when you do a breath test. So I'm hoping you can see my little arrow here. But we have a patient here who at the control, sample number 1, right, had a rise of parts per million of hydrogen of 3 and a parts per million of methane of 13. Then as we go along, 20 minutes, 40 minutes, 60 minutes, you can really see that methane jumped up to 19 here at the 40-minute mark, and then at the 80-minute mark, we went from 3 to 27. The diagnostic criteria is more that within the first 90 to 100 minutes that you see a rise of 20 or more. There are other extenuating circumstances where that may be different, especially with methane, where you even a few numbers, well, you went from 11 here to 19, that's a pretty big jump, and then to 25. So it just continues to rise here for this person. At this point, at 120 minutes, depending on if this person was constipated, and she actually was constipated, I would actually also use the practitioner's discretion of, like, did that test sugar actually reach your large intestine yet? So we do extend it to 3 hours so that practitioners can really use their own discretion. This person had a tremendous amount of fermentation here. We do expect to see, as it hits the large intestine where bacteria live, we do expect to see fermentation, and we do expect to see gas rises. But when you see here combined of 16 and then going all the way to 153, that's a huge and tremendous gas rise. On the graphical, we can see the combined was the green here, the hydrogen really high in the blue, and the methane in the red. After treatment, I think this is the same patient, and we actually had to do quite a number of courses of antimicrobials, but you can see here the follow-up where her methane was non-existent practically, and her hydrogen is practically within the normal range, even though we do see a 5 to a 37. Technically that's still considered positive, but the individual symptoms of this patient, where her symptoms were completely resolved, and we could say that that's just the normal rise in the large intestine. So again, up to the practitioner, but this would be considered theoretically positive. But beautiful reduction in methane gas and hydrogen gas along the way, and here's the graphical representation of that. So, one of the questions I often get is like, okay, that's great, and why don't I just tell people to go on the diet, and why should we test? Well, because it's a very specific condition that requires very specific treatment, and also, had I not known in the previous case here, had I not known exact gas levels, I wouldn't know how many bouts of or courses of antimicrobials I should do. So I think it's really important from a therapeutic perspective to understand the level of gas, because that will really guide your treatment. One of the things is, or one of the most common reasons why I see people that have been referred to me for SIBO is because their treatment was either ended prematurely, which ended in a relapse, or they were never really tested. They were just given rifaximin or herbal antimicrobials, and they still had the same symptoms. So it is a specific condition that requires, I think, better understanding and better testing. So the resources, just before we get into the diet and so forth, but I just want to alert you to that at SIBOtest.com we do have an entire practitioner resource section. You can sign up for free. The SIBO diet handout that we'll get into in a minute is there. You can download it. It describes the diet in detail. It has recommended natural products. There's also a handout that you can download that you just give to the patient, and those are ordering instructions. So it's really, really easy for you to, as a practitioner, I'm a practitioner, I don't have time to fill things out for a person. So you just say, look, order the test online, and it's really easy. There's also a 4-minute educational video that we've made of what is SIBO, more for the lay person, and also a quiz, so you can sort of weed people out. If they don't test really high on that test, we often don't recommend that they do testing. So you can have a look at that at your leisure. So the diet, or the treatment rather, is based on 3 key areas. The diet is restricted for 3 months minimum, and that's a combination of specific carbohydrate diet and FODMAP diet together. FODMAP, of course, Monash University did really amazing research that really found out about these fermentable fibers in foods that these bacteria feed on, and that's not just limited to fruit, but also a number of vegetables and grains and so forth. But the diet is pretty restrictive, as we'll see in a minute. And then we use antimicrobial therapy, which we'll get into, and prokinetics, which basically aim to reset the migrating motor complex. And I think that is really what sets the treatment apart, is this real focus on prokinetics. Often I do use hydrochloric acid or enzymes as well as gut-healing nutrients. But the key thing here also is, just like with certain probiotics that contain prebiotics like inulin, these are contraindicated in SIBO, as is slippery elm, aloe, and certain gums, because these all contain polysaccharides, and that's just another starch that's digestible by bacteria that are present in the small intestine. I hope you can see this.
Yeah, yeah, we definitely can. As we get into the last 10 minutes, everybody, I've got a few questions coming in, so I'll ask those at the end of the session, but now's a good time if you do have some questions, if you write them in, and we'll try to get Nirala to answer them just after she's finished the session. But if you do have them,
okay.
I haven't asked them, I'm just waiting for Nirala to get through important information, and then I'll ask them.
This hour just flew by, didn't it?
Yeah, it's great.
It's something I could talk about until the cows come home,
yes.
I guess. Okay, so if you can see this on your screen, and you can see it on your handout, but again, you can download it once you sign up as a practitioner at SIBOtest. You can download this and have actually a color copy and hand it out to patients and stuff like that. But really what it is a diet. You have SIBO diet active phase, that's the active treatment for 6 weeks minimum, and then maintenance. Oh, sorry, that's the next slide. But so this whole slide is basically active phase. And what we've done is, for those of you who have listened to me speak on this topic before, I've really revamped the diet, and I'm about to do it again, but it'll be uploaded onto SIBOtest when the new diet has come out. It's not that different from what we see now, but just as information comes in from FODMAP, from Monash, I do adjust my handouts to reflect the current research. But basically, it's a diet that's high in protein. You're avoiding dairy. You're starting off always with Group 1 SIBO foundation diet. Let's say you have somebody, you've just tested them, they're positive, and you start them on the diet and all the other antimicrobials, etc. They start out with Group 1 foundation diet. When their symptoms have improved about 80%, which can be after a week or 2 weeks on the foundation diet, they're allowed to move on to Group 2 because you're still in active treatment. But those that are very sensitive, you want to maintain SIBO foundation diet until you see them. I usually see people after 3 weeks of starting the treatment, just so that I can tweak and adjust my treatment. But then you have your vegetables that are unlimited, more or less. And then these are the vegetables in the third column or the third box here that are limited, And I will actually take out artichoke hearts altogether and beets altogether in my new handout, because I just I don't even want to risk it, and I'll add some other things into it. But basically they're very high in FODMAPs. But again, I mean, who eats an eighth of a cup? Who bothers to measure out eighth of a cup or 2 slices of beetroot? So, but these are more limited because of their higher FODMAP content. Then we go down to fruit. There's nothing but lemons and limes. And then also all grains are, hang on. Oh, hang on. Yeah, okay. Grains and starches are going to be avoided. That's including all grains, including quinoa and white rice initially, but eventually you transition them into jasmine rice and basmati rice, as is in this SIBO moderate diet here in group 2. And then lentils and legumes are totally avoided. And just have a look through all that. And also nuts and seeds are a lot more restricted than I used to. My almond meal pikelets are now half coconut flour. So we do have some recipes in the handout itself. So then after the treatment, that's the perfect time to actually retest. And you do want to make sure that you retest, especially if they had a very high gas level, because every course of antimicrobials, you can expect to reduce gas about 20 to 30 parts per million, depending on if they're hydrogen or methane. So this is just stuff that over the years I've just learned of testing and testing and testing of what really works there. Then you can move them on to maintenance diet, right? And the maintenance diet is actually for more than 6 weeks. You can keep them on that until they're really clear, and then what you do is you move them on to just FODMAPs and prokinetics. Okay, so I've just really done sort of the quick and dirty of this dietary approach, but the treatment really is, the key is that you do your antimicrobials for 6 to 12 weeks. Then, as I've mentioned, you can expect the gas reduction to be between 25 and 35 parts per million during each treatment period. And then the other thing is methane and constipation cases are much harder to treat, so don't despair when it's very slow going with those cases, and then also retest to assess your results. The other thing is prokinetics, which are herbs and nutrients which stimulate this migrating motor complex, and these may be dosed up to a year. So that's often what I do. I rotate through them, and I think we will get to that in a minute. The diet is quite restricted for 3 to 12 months. So three months treatment and then FODMAP often, or just keep them on the maintenance diet. There's no diet that fits every SIBO case. You have to kind of see what works for people. Some people can introduce homemade yogurt a lot sooner, or cheese, or if they're or never, because they're dairy sensitive. Some people may need more rice because they're losing weight. So you're gonna have to just start to try out some of these points and see how you go. So let's talk about herbal antimicrobials a little bit. For your hydrogen dominant SIBO cases, you want berberine-containing herbs, and that's Oregon grapefruit, philodendron. I often use Bactrex from Metagenics, which has both philodendron and oregano oil, as well as hydrastis, but of course hydrastis is getting harder and harder to find, as well as barberry. And for your high methane cases, high allicin garlic, so not just garlic tincture or garlic capsules, but I use Biomedica Alimax, although they've just changed their formula, so I'm going to have to do a bit more research to see if that's really still very legit, but I'm using it right now and it seems to be okay. It's a very good garlic product. And then for both cases, neem and oregano oil. So these are the things that are really tried and proven. These will work, and I'm working on expanding this repertoire I'm always looking into other herbs. I'm looking at manuka, I'm looking at colloidal silver, and as if you find that something is really working for you, I need to hear from you, because we always need to update our sort of armamentarium, if you will. Now the prokinetics, and I'm sorry that I have to talk really fast now, but basically they aim to reset the normal motility, and it's one of the reasons why your treatment won't work if you don't use this, because it will just come back, right? And you may need to rotate these to find effective prokinetics. I use often a combination of herbal bitters because it has this dual effect of increasing digestive juices. But my sort of formula is gentian, dandelion, Oregon grape, and I use Bakel skullcap or yellow dock. If they have more sort of gallbladder involvement, I use the yellow dock. Bifidobacterium infantis is also something that looks very, very promising, and sometimes I start people, especially with very constipated patient, I use the NeoCare from Biomedica, which is, you know, I mean, it's very low dose, but it's pure Bifidobacterium infantis. And then 5-HTP and acetyl L-carnitine. 5-HTP, of course, to increase serotonin in the large intestine, and that's a peristaltic stimulant, as well as acetyl L-carnitine, which is sort of a precursor to acetylcholine, which also regulates peristalsis. And then some final thoughts is that it's a real extremely common condition, and you want to really think of that first when somebody comes in that's been diagnosed with IBS. And improper treatment, like just treating Candida, will not resolve this, and you will just have people that are continuing to have symptoms. And also consider your patients that get a return of their symptoms as soon as they deviate from their diet. And then retesting is really very recommended, as I've mentioned. Just some, I have one more slide after this that I want to mention quickly, but thank you for your attention. Again, SIBOtest.com, you have a practitioner resource section. There's a SIBO webinar that's available to you, and you can sign up for the news where I try to stay current with the research. And another thing is we're really updating actually the website with a new design, and also if you ordered 3 or more tests, you get your own page as a SIBO treating practitioner on our website. So currently we've got quite a few in the different states. We need somebody from the Northern Territory and from Tasmania, yes. I think. That's my website. There's some information on, I do a clinical seminar series through AMPA, and I'm doing one next month that I'm going to talk about in just a second. But SIBOinfo.com is Dr. Alison Seebecker, also great information, especially if you have somebody that wants to get rifaximin. Rifaximin is an excellent antibiotic for hydrogen dominant. It's hard to get, and it's really expensive, but it is available. So just very briefly, this is happening March 15th in Brisbane, and I think it's in April in Melbourne. We're still trying to solidify the sponsors for that event in Melbourne. But what I'm doing is I sort of do day-long immersion days for practitioners, and this particular one is about digestion, where I don't just talk about SIBO, but I talk about food allergies and chronic constipation and etc. But the real sort of what I am passionate about is clinical excellence and clinical competence in Australian practitioners. So the whole hour and a half to 2 hours at the end of the day is dedicated to practicing physical exam skills. There's so much you can do to help to identify what's really going on with somebody. So you can check that out. It's on the AMPA website, and have a look around. It's also, I think, on my website, so if you are interested. So thank you very much, and if there are any questions.
Thanks so much, Nirala. Thanks so much, Nirala. That was brilliant. I'm sure we've got most people stayed for the whole hour and a bit, and it's I've got some questions to ask. So I just want to, before we go to the questions, I want to thank yourself for presenting and facilitating tonight's webinar. There's so much information there, and we can just really tell, obviously from you've got a passion, but you've got so much experience in this area, so what you're saying is very educated. So I think that's why everyone's just grasped on the words that you've said tonight. But I want to thank you, and I want to thank everyone for just attending tonight. I'm about to go to the questions, but in case I do advertise it for an hour session, and the questions are going to go a bit longer, so if you do have to go, I am recording the session, and this will be put up on the careers website, which you can all can access. So if you do have to go, thank you for attending, but I'll just go through the questions bit by bit now.
Okay.
Where are we? The first one. Okay, so this is from Danielle. If a patient has mouth or tooth pathologies, periodontal disease, gingivitis, implant infections, etc. Can this impair the accuracy of the breath test?
Great question. You know, because we're really testing hydrogen and methane, and we're really looking at the timing also. So I would say that I would expect that patient to have a higher baseline. But then really what we're looking for is the movement of the gases through the small intestine, so you can still very much deduce from the results in terms of whether or not they really have the presence of of bacteria in the small intestine, not just the mouth.
Great. And a second part of that was, are there any other factors to consider about breath test accuracy to diagnose SIBO?
Well, no test is perfect, right? So
yes.
I think Dr. Pimentel actually reckons that, I mean, we use the Quintron machinery, which is the gold standard for breath testing, but it's about 85% accurate, right? If you wanted the most accurate is a